Now take a look at this question. Pause this video if you have to and read through this question, and I want you to answer one question for me at the end. What is the type of shock? Is it hypovolemic shock? Is it cardiogenic shock? Is it distributive shock? Or is it obstructive shock? Pause the video and think it out. Okay, so if you're done with the question, then we'll get back to this and we'll get back to the answer as well uh, after the explanation. But I'm sure many of you must have got this right. If not, then I'll explain why not. I'll explain everything behind it. So this is cardiogenic shock. This is cardiogenic shock. I'll get back to this. We'll get back to this, why it's cardiogenic shock and how these parameters change. So take a look at this simplified diagram of the heart. This is the heart. You have the left atrium, the left ventricle. You have pulmonary vein bringing oxygenated blood, and aorta that is taking out the oxygenated blood. Left ventricle is pumping it to the aorta, which goes to the rest of the body. Now, in terms of function of the left ventricle, I want you to remember three important parameters in terms of shock. This is what the USMLE will give you. The first one is called cardiac output. Cardiac output is basically how much blood the left ventricle is pumping out into the aorta. Simple. How much blood is the left ventricle pumping into the aorta? Now, the USMLE may use other fancy terms for cardiac output. They mean one and the same thing. Stroke volume. Stroke volume is basically the amount of blood pumped in one beat. Cardiac output is the stroke volume into the heart rate. Basically, it gives you an idea of the same thing, how much blood the left ventricle is pumping. Or they might even trick you with something called cardiac index. Cardiac index is basically cardiac output per square meter divided by the body surface area. That is, if you see either of these three parameters in a question involving shock, that means they're basically telling you how much blood the left ventricle is pumping out. That is exactly what they're telling you. That's all you have to think about. Okay, any of these three parameters. Now, the second major parameter that I want you to remember is something called systemic vascular resistance, which is basically the afterload. This is the pressure in the peripheral arterioles or arteries and arterioles that the left ventricle is pumping against. So the higher the pressure in the peripheral arterioles, the more effort the left ventricle has to put into pumping blood out. So when you see systemic vascular resistance or SVR, I want you to think of only one thing. I want you to think of, are the arteries constricted or are the arteries dilated? Is there vasoconstriction or is there vasodilation? If there's vasoconstriction, SVR will rise. If there's vasodilation, SVR will fall. That's the only. SVR equals vasoconstriction. Cardiac output equals left ventricular output. And the third and another important parameter is related to the left atrium and the pulmonary vein, that is the preload, which is the pulmonary capillary wedge pressure. Remember this is a third important parameter. You have cardiac output, you have systemic vascular resistance, and the third is pulmonary capillary wedge pressure. This is basically the pressure that is measured in the pulmonary capillaries. But on a question of shock, when you see PCWP, I want you to think of only one thing. PCWP equals to left atrial pressure. PCWP equals to left atrial pressure. It's not an exact mathematical equation, but when you see PCWP on the USMLE, I want you to think that the question is telling you about the left atrial pressure. So if PCWP rises, that means left atrial pressure has risen. If PCWP falls, that means left atrial pressure is low. Now let's take a look at how these three important parameters change in setting of left ventricular failure. Left ventricular failure, that is cardiogenic shock. So left ventricular failure. Now imagine this is a river and you've suddenly built a dam across it. It was freely flowing. Water was freely flowing. Now you've suddenly built a dam. What happens to the downstream part of the river? Of course, the pressure of water will decrease. The volume of water that's going into the aorta will decrease. And what happens upstream? If you built a dam here, what happens upstream? Water will start clogging behind. It will start building up. It will start building up in the left atrium, in the pulmonary vein. Pressure will start rising. So how does that translate in this case? In the case of left ventricular failure, how does it translate in case of blood? Stroke volume will decrease. First thing, left ventricle has failed. Easy, stroke volume will decrease, cardiac output will decrease. That's where the primary pathology lies. Second, what will happen? Stroke volume decreases, that will cause a fall in the blood pressure. There's decreased pressure downstream, so fall in blood pressure, and that will activate your sympathetic nervous system. And what does the sympathetic nervous system do to the peripheral arterioles? It causes vasoconstriction. It causes vasoconstriction. Now, what did I tell you? What do you have to remember when you hear the word vasoconstriction? You have to think of systemic vascular resistance. Systemic vascular resistance in case of vasoconstriction will rise. Whereas in case if there was vasodilation, resistance would fall. But in case of cardiogenic shock, you have vasoconstriction due to the sympathetic nervous system, which is secondary to the fall in blood pressure. This causes a rise in systemic vascular resistance. And now when systemic vascular resistance rises, that causes shunting of the blood. The blood that's going to the vessels in the periphery in your limbs, they constrict. So blood is diverted away from your limbs and to the vital organs at the center of your body, especially the brain. So if there's less warm blood flowing to the limbs, that causes cold, clammy extremities. Cold, clammy extremities, very important. Especially you'll see this in case of cardiogenic shock, and also you'll see this in case of uh, hypovolemic shock. Hypovolemic shock, very important. Now let's go to the atrial part. Let's go to the atrial part. Left atrial pressure, PCWP. What happens when the left ventricle, when you build a dam across the left ventricle? The pressure rises, pressure backstream rises, left atrium dilates, left atrial pressure rises. So what happens to PCWP? PCWP is essentially equal to left atrial pressure. For all intents and purposes, for the USMLE, PCWP equals left atrial pressure. So when you build a dam across the left ventricle, left atrial pressure rises, so PCWP rises. Very good, very good. So how does this affect the pulmonary vein and the lungs? Now, if left atrial pressure rises, what happens to pulmonary vein pressure? It also rises. Blood is being backed up into the left atrium. From the left atrium, it's being backed up into the pulmonary vein, and from the pulmonary vein, it's being backed up into the small pulmonary capillaries. So pulmonary capillary pressure rises. This is all transmitted from the left ventricle into the left atrium and into the pulmonary capillary. Because of pulmonary capillary pressure rises, fluid will extravasate outside from the capillary into the surrounding lung tissue, the pulmonary parenchyma. This gives you pulmonary edema. Pulmonary edema, telltale sign of cardiogenic shock. But how will the USMLE give you? They won't say pulmonary edema. They'll give you important clinical findings. The first is bibasilar crackles on chest X-ray. So on the base of the lungs, both the lungs, you'll hear crackles on auscultation. Why the base? Why the base? Because that's where fluid gravitates. When you're standing or sitting, that's where fluid gravitates, at the bases. So you'll hear bibasilar crackles, and chest X-ray will show something that they call a batwing appearance, or they might even show you curly bee lines. Curly bee lines are basically fluid in the fissures of the lung. This is the fluid that has come out of the pulmonary capillaries. So this is what I want you to remember. In case of left ventricular failure, these three major parameters: cardiac output decreases, that's the primary pathology. That leads to a secondary rise in systemic vascular resistance because of sympathetic nervous system mediated vasoconstriction, systemic vascular resistance. And lastly, PCWP, because of backing up of blood behind into the left atrium, PCWP rises. That causes secondary pulmonary edema. Okay, very good. Now take a look at the right side of the heart. Take a look at the right side of the heart. Here we have the right ventricle, the right atrium. This is the SVC and IVC that brings deoxygenated blood from the rest of the body into the right atrium. Then the right ventricle pumps it out to the lungs. Now, right ventricular failure usually occurs secondary to left ventricular failure. So the primary pathology in cardiogenic shock is left ventricular failure that causes backing up of blood into the left atrium, that causes backing up of blood even further behind into the lungs, and from the lungs backing up of blood into the right ventricle. Then eventually at one point the right ventricle will fail. Now just like we had three parameters for the left side of the heart, we have two parameters to think about for the right side of the heart. The first parameter is something fancy called central venous pressure. Central venous pressure. This is basically the pressure measured in the superior vena cava. The pressure measured in the superior vena cava. And the second fancy term that we have is mixed venous oxygen saturation. Mixed venous oxygen saturation, or SVO2. SVO2 is the oxygen saturation in venous blood. That is, suppose the superior vena cava, or it can even be the IVC. Now, mixed venous oxygen saturation will give you the it will give you an idea of how much oxygen is being extracted by the body. How much oxygen is being extracted by the body. So if SVO2 is low, that means the body has extracted a lot of oxygen and very little oxygen is remaining in the SVC as it comes into the right atrium. Whereas if SVO2 is high, that means very little oxygen has been utilized by the rest of the body, and a lot of oxygen has spilled into the SVC and back into the right atrium. That's all I want you to think about. And just like for the left atrium, we had PCWP. PCWP equals left atrial pressure. The same way, for the right atrium, I want you to think of CVP. CVP, central venous pressure, for all intents and purposes of the USMLE, CVP is right atrial pressure. Now, let's go to the pathology. The pathology, right ventricular failure. The right ventricle has failed. Use the same analogy that you use for the left ventricle. Blood will back up. You built a dam across the right ventricle. You built a dam to cut the flow of water across the right ventricle. So blood will back up. Water will back up into the right atrium. So what will happen to the right atrial pressure? What will happen to right atrial pressure? Right atrial pressure will rise. Central venous pressure will rise. So pressure in the SVC will rise. All this pressure will again back up to the rest of the body. It will back up in the rest of the body. And in case of right side of the heart, I want you to think of three extremely important organs. These three extremely important organs are where you'll see clinical signs of right-sided heart failure. Right-sided heart failure. The first is the external jugular vein. Very important, probably the most important. External jugular vein. You can feel it at the side of your neck, or you can see it at the side of your neck. External jugular vein, in case of backing up of blood because of right ventricular failure, you'll see dilatation of the external jugular vein, and on the USMLE they'll give you a sign called JVD, or jugular venous dilation, jugular venous distension or dilation. Telltale sign of right ventricular or right-sided heart failure. So if you see JVD, you think something is wrong with the right heart. JVD, something is wrong with the right heart. The second thing that will happen is the IVC pressure has backed up into the IVC, and immediately below the diaphragm, the IVC empties the hepatic veins, that is the liver. So you'll get hepatomegaly. Blood will back up from the IVC into the liver. You'll get hepatomegaly, and you'll even get jaundice and other signs of liver failure, like elevated liver enzymes and stuff like that. And the third thing is the limbs, the hands and feet. But more important for us is the feet. You'll get peripheral edema. Just like fluid extravasates from the left atrium into the lungs and causes pulmonary edema in case of left ventricular failure, the same way in case of right ventricular failure, fluid will extravasate into the limbs and cause peripheral edema. Now, this will be more prominent in the lower limbs because that's where gravity, that's the dependent portion of your body. So you'll see peripheral edema in case of right ventricular failure. Very important, very important. Now suppose you see a question that gives you hepatomegaly. There's hepatomegaly and there's peripheral edema, but it doesn't give you JVD. There's no JVD. The neck veins are said to be flat. They're said to be normal. Then what would you think? What would you think? Then is it something related to the right side of the heart? No, it's not. It's not, because JVD is a telltale sign of right ventricular failure. If you only see hepatomegaly or you see peripheral edema, it's something beyond the heart, probably something like Budd-Chiari syndrome. Budd-Chiari syndrome, where the hepatic veins are clogged, and that's causing backstream, distension of the liver, or the IVC is clogged, which is causing hepatomegaly and peripheral edema, that is lower limb edema. And so JVD is is probably the most important factor that you look for, clinical finding that you look for in case of right ventricular failure. So for right-sided heart failure, we have central venous pressure, which is right atrial pressure. We have mixed venous oxygen saturation. Mixed venous oxygen saturation in this case will go down. Mixed venous oxygen saturation will go down. Why will it go down? Why will it go down? Because now the left ventricle has failed, and blood is not being pumped out into the to the rest of the body. So the body has very little blood to supply oxygen to it. So out of this little blood, the body will extract every last molecule of oxygen, every last molecule of oxygen. They won't leave any oxygen behind. That's why the oxygen that returns back to the heart will be so low, that mixed venous oxygen saturation will fall in case of cardiogenic shock. So there we have it. We have a rise in CVP, fall in mixed venous oxygen saturation. You'll see JVD. They might even give you hepatomegaly and peripheral edema. You see these, you think right heart. You see especially JVD, you think right heart. Something's wrong with the right heart. Okay. Now take a look at this table. Very important table. You'll see this table in practically every textbook, every resource that you use, which compares the types of shock. So we'll be comparing hypovolemic shock, we'll be comparing cardiogenic shock, obstructive shock, and distributive shock. So the first thing that we'll compare, first we'll see examples of each. Hypovolemic shock. What's the most common example of hypovolemic shock? Massive blood loss. Think of massive blood loss. Whenever you think of hemodynamic parameters pertaining to hypovolemic shock, I want you to think of massive blood loss. For cardiogenic shock, I want you to think of two things, either myocardial infarction or congestive heart failure. Anything. Myocardial infarction can lead to congestive heart failure as time progresses. For obstructive shock, I want you to think of two things. The first one is pulmonary embolus, and the second is cardiac tamponade. Now, pulmonary embolus, I want you to think of very specific type of pulmonary embolus, which is called a saddle pulmonary embolus. A saddle pulmonary embolus, which is a big fat embolus right at the bifurcation of your pulmonary trunk. It's blocking all the blood going from the right ventricle to the lungs. It's not I'm not talking about a small embolus in a far off lobe of the lung. I want to talk about a big fat saddle pulmonary embolus sitting in the main pulmonary trunk that's blocking practically all the blood your right ventricle can pump. Okay, and cardiac tamponade. That's what I wanted to think. Two examples I wanted to think of for obstructive shock. And distributive shock, we have three examples. The first is septic shock in case of bacterial infections. The second is anaphylactic shock. Anaphylactic shock will cause a release of histamine. Histamine is a potent vasodilator. You'll get widespread vasodilation. Septic shock, bacterial toxins will cause vasodilation. Neurogenic shock, the third type of distributive shock. Neurogenic shock will cause vasodilation because you have cut out the sympathetic nervous system. That's dysfunctional. Sympathetic nervous system, which controls the vessel diameter, is gone. So there'll be widespread vasodilation. Okay. Now the first parameter, PCWP, left atrial pressure. PCWP equals left atrial pressure for all intents and purposes. What will happen in case of hypovolemic shock? What will happen to left atrial pressure? See, there's no blood at all in hypovolemic shock. There's so little blood it can't even exert any pressure. So left atrial pressure will fall. Left atrial pressure will fall. Cardiogenic shock, we just saw this, blood will back up behind from the left ventricle into the left atrium. So left atrial pressure will rise. Very good, very good. Obstructive shock. Now think of a saddle pulmonary embolus. There's no blood going from the right ventricle into the pulmonary trunk. So no blood going to the lungs, and thus no blood can come back from the lungs into the left atrium. No blood can come back into the left atrium. So what will happen to left atrial pressure in case of a saddle pulmonary embolus? Left atrial pressure will fall. Exactly, left atrial pressure will fall because there's no blood coming back. In the same way, if there's a small pulmonary embolus, left atrial pressure will still fall, but to a lesser extent. So pulmonary embolus, left atrial pressure will fall. But what will happen in case of cardiac tamponade? Now you see in cardiac tamponade, blood is trying to fill into the left atrium. Blood is filling into the left atrium, but there is so much pericardial fluid outside the heart that the pericardial fluid is exerting inward pressure from the outside. So even if blood is trying to fill in from the inside of the heart, the outside pressure will exert, the outside fluid will exert pressure that will resist filling of the left atrium. So left atrial pressure in this case will rise because you're trying to fill, imagine you're trying to fill a balloon, but at the same time you're compressing the walls of the balloon. You're trying to fill the balloon, but you're compressing both walls of the balloon with your hand. So of course the pressure inside will rise. How much will you fill? You can't, at one point it will just pop. So left atrial, in case of cardiac tamponade, left atrial pressure will rise. You see this conflicting thing. So the PCWP or left atrial pressure in case of obstructive shock will rise or fall depending on the etiology. Depending on the etiology. Now, in case of distributive shock, what will happen to PCWP? Now, think of widespread vasodilation. Widespread vasodilation. There's no, I mean, blood is just pooling around in the peripheral limbs, and in your peripheral limbs, it's not coming back to the body. It's not coming back. Sorry, it's not coming back to the heart. It's not coming back to the heart. It's just lying and waiting in your peripheral limbs. So what will happen to the left atrial pressure if blood is not coming back to your heart? There's no venous return. Venous return has dropped. What will happen? What will happen? Left atrial pressure will fall because there's no blood coming back. Now the next parameter, PCWP, you got the distribution of PCWP across the 4 types of shock, left atrial pressure across the 4 types of shock. The next parameter, cardiac output, rest, stroke volume. In case of hypovolemic shock, what will happen to cardiac output? Well, you see, the heart is pumping as much as it can, but there's no blood to pump out. There's no blood to pump out. So what will happen to the output? Output will fall. Naturally, output will fall. Cardiac output will fall. Similarly, cardiogenic shock. The pathology is the left ventricle is damaged. Left ventricle is dead. What will happen to cardiac output? Decrease. Obstructive shock. In this case, what will happen to left ventricular output? What will happen to cardiac output? Think of pulmonary embolus. There's no blood coming back to the left side of the heart. So left ventricular output will fall. And in case of cardiac tamponade, you see there's very little blood that the left ventricle can accommodate. Left ventricle can't even dilate properly, so it can't accommodate blood, and so it can't pump out blood itself. It can pump out all the blood that it can accommodate, but the amount of left ventricular end diastolic volume is so low that cardiac output will also fall because it's not getting enough blood to pump out, so cardiac output falls. In distributive shock, what will happen in distributive shock? Yeah, now this is a good one. Distributive shock. You see the left ventricle. Now in case of septic shock or anaphylactic shock, there's widespread vasodilation. And so blood pressure has fallen. So the sympathetic nervous system will get activated. Sympathetic nervous system gets activated, and the heart starts pumping harder. It starts pumping faster. So what happens? Cardiac output rises. The body is trying to compensate for all that widespread vasodilation. But then what happens in case of neurogenic shock? In neurogenic shock, you don't have a sympathetic nervous system. If you don't have a sympathetic nervous system, you can't increase your heart rate. You can't increase your contractility. There's nothing to push the heart to pump harder and faster. So in case of neurogenic shock, cardiac output will fall. So again, for distributive shock, cardiac output depends on the etiology. Okay, next. Right atrial pressure, central venous pressure, right atrial pressure. Hypovolemic shock, it should be easy. There's no blood to exert pressure, so right atrial pressure will fall. Cardiogenic shock, we just saw this. Blood will back up from the right ventricle into right atrial, and right atrial pressure will rise. Obstructive shock. This is a good one. Obstructive. Think of a pulmonary embolus. Right ventricle cannot pump out blood. Because there's a big fat embolus that is blocking its pathway. So right atrial pressure will it rise or fall? If blood is backing up from the right ventricle into the right atrium, right atrial pressure will rise. Same way, cardiac tamponade, right atrial pressure. The same way left atrial pressure rose with cardiac tamponade, the same way right atrial pressure will rise, because the right atrium can't distend, but you're still filling it with blood. You're filling a balloon with water, but you're also compressing the side of the balloon at the same time. Right atrial pressure will rise. And distributive shock, what will happen to right atrial pressure and distributive shock? You see venous return, you don't have venous return. There's no blood coming back from the SVC or IVC because there's so much vasodilation. Blood is just pooling and sitting around in the body. So right atrial pressure will fall. If you don't have blood coming back, you don't have venous return, right atrial pressure will fall. Next, afterload, SVR. Systemic vascular resistance. What do you think of when you say systemic vascular resistance? What do you think of? You think of vasoconstriction or vasodilation. Hypovolemic shock. Will there be vasoconstriction or vasodilation? See, if you don't have blood, then your sympathetic nervous system will compress your arteries, constrict your arteries. You'll get vasoconstriction, so SVR will rise. Cardiogenic shock, fall in blood pressure because left ventricle is not pumping blood. Sympathetic nervous system will activate and you'll get vasoconstriction. SVR will rise. Obstructive shock, again, think of pulmonary embolus. No blood coming to your left ventricle, cardiac output is down. No blood leaving the left ventricle because cardiac tamponade, so left ventricle is, so blood pressure is low. Blood pressure is low, sympathetic nervous system will activate and cause vasoconstriction. Rise in SVR. Distributive shock. The whole pathology of distributive shock is based around SVR because bacterial toxins won't allow vasoconstriction and histamine won't allow vasoconstriction. Histamine is a potent vasodilator. So anaphylactic shock, vasodilation. Neurogenic shock, there is no sympathetic nervous system. Sympathetic nervous system is dead. Neurogenic shock will cause vasodilation. All of distributive shock will cause vasodilation and SVR will fall. And the last parameter, mixed venous oxygen saturation. In case of hypovolemic shock, are the tissues extracting oxygen? Are they extracting every last molecule of oxygen? Yes, they are, because there's so little blood to work with. There's so little oxygenated blood to work with that the tissues have to extract every last molecule of oxygen. So SVO2 will fall. The oxygen that is returning back to the body in the veins will fall because everything is being extracted. Cardiogenic shock, same reason. Oxygenated blood isn't reaching the tissues. When so little oxygenated blood is reaching the tissues have to extract every last molecule of oxygenated blood, and SVO2 will therefore fall. Now, obstructive shock, same pathology. Think of pulmonary embolus, think of cardiac tamponade. Cardiac output is low. Oxygenated blood is not reaching the tissues. So tissues extract every last molecule of oxygen. Every last molecule that they have to spare, they will take it. And when they take every last molecule of oxygen, how much oxygen will return back into the So obstructive shock, pulmonary embolus, cardiac tamponade. Every last molecule is extracted. Because cardiac output has fallen. SVO2 will decrease. Now, in case of distributive shock, there's a lot of blood pooling around, but you see bacterial toxins and anaphylactic, histamine, they interfere with the mitochondria. So even though there's a lot of blood, the tissues don't extract everything because there's so much oxygenated blood pooling around that the blood that returns with a lot of oxygen in it. So in distributive shock, you'll get an increase in your mixed venous oxygen saturation because the tissues are underutilizing that oxygen. Primarily in septic shock because of bacterial toxins that cause mitochondrial dysfunction at the tissue level. So this is a tissue related pathology. You'll get a rise in your mixed venous oxygen saturation. Okay, so now let's get back to our question. A 68-year-old man is brought to the ED because of severe shortness of breath and chest pressure for 2 hours. He has a history of hypertension, type 2 diabetes mellitus, and prior myocardial infarction. On examination, temperature, he is afebrile, temperature is normal. Blood pressure, what do you see with blood pressure? He is hypotensive, blood pressure has fallen. What do you see with the heart rate? Heart rate is high. What does this signal? This signals the sympathetic nervous system is activated. Because blood pressure has fallen, sympathetic nervous system is activated. Next, respiratory rate is high. Okay, oxygen saturation on room air is 88%. Okay, he appears anxious and diaphoretic. JVD is present. Jugular venous distension is present. Bibasilar crackles are heard on lung auscultation. Extremities are cool and clammy. ECG shows ST segment elevations in leads V1 to V4. Hemodynamic measurements are most likely to show which of the following. So we already discussed this. This is which type of shock? We already saw the type of shock that this is. This is cardiogenic shock. You can see it's a clear MI, ST segment elevations. You see cardiogenic shock. As I mentioned, jugular venous distension, telltale sign of right-sided heart pathology. Something is wrong with the right side of the heart. Bibasilar crackles, something is wrong with the left side. Left side is backing, the blood on the left side is backing up, causing pulmonary edema. That's causing bibasilar crackles on auscultation. Bibasilar crackles. Extremities are cool and clammy. Because systemic vascular resistance is raised. Blood is being shunted away from the extremities and towards the vital central organs, especially the brain. So extremities, there is no warm blood in the extremities. Extremities are cool and clammy. Telltale sign, another telltale sign of cardiogenic shock. Low blood pressure because cardiac output is low. Low blood pressure, cardiac output is low, which is activating the sympathetic nervous system, causing increased heart rate. And as you can see, he has a history of hypertension, type 2 DM, myocardial infarction, which are all signs of atherosclerosis. This is a confirmed repeat myocardial infarction. So in case of cardiogenic shock, what happens to cardiac output? What happens to cardiac output? Cardiac output falls. So either B or C. Cardiac output falls. PCWP. What is PCWP? Pulmonary capillary wedge pressure. PCWP is left atrial pressure. In cardiogenic shock. What is left atrial pressure? What happens to left atrial pressure in cardiogenic shock? Blood is backing up. You've built a dam across the left ventricle. Causing backing up of blood. Increase in left atrial pressure. Increase in PCWP. You see in option B or option D. So it's either option B or option D in this case. Systemic vascular resistance. What is this? Vasoconstriction or vasodilation? What do you think of for systemic vascular resistance? You think vasoconstriction or vasodilation? If there's constriction, SVR will rise. If there's dilation, SVR will fall. In case of cardiogenic shock, what is happening? Is there constriction or is there dilation? See, sympathetic nervous system is activated. You see the heart rate. Sympathetic nervous system will cause vasoconstriction. It will cause systemic vascular resistance to rise. There will be a rise, so it's either B or it's either C or it's either E for systemic vascular resistance. And mixed venous oxygen saturation. A dam across the left ventricle. There is no downstream flow of blood. Tissues are getting very little blood to work with, very little oxygenated blood to work with. So they will hungrily extract every last molecule of oxygen. And so almost zero oxygen will return back to the heart. Zero oxygen in the venous blood because everything has been hungrily extracted. Mixed venous oxygen saturation will fall, and it will fall dramatically. So there you get either option B or option C or option E in this case. So what's common? The common is option B. You see a fall in cardiac output. You see a rise in pulmonary capillary wedge pressure or left atrial pressure. You see a rise in systemic vascular resistance. You see vasoconstriction. Mixed venous oxygen saturation falls because tissues are hungrily extracting every last bit of oxygen. So we got this clear. I hope cardiogenic shock is clear to all of you. I hope you can differentiate quickly between the type of shocks, and all the very best for your USMLE.